If your feet burn at night, if your hands go numb for no reason, or if you feel electric shocks in your legs, what I'm about to reveal could determine whether you walk independently in 5 years or not. Because the real cause of nerve damage isn't aging, and it isn't just diabetes. It's something you're exposing your nerves to every single day, and if you don't stop it now, the damage may become permanent. Neuropathy does not suddenly appear the day you feel tingling in your toes or burning in your feet. What most people experience as a new problem is actually the final stage of a process that has been unfolding quietly for years. Nerves are delicate biological wires that rely on a steady blood supply, stable blood sugar levels, adequate nutrients, and low inflammation to function properly. When those conditions are disrupted repeatedly, even slightly, damage begins at a microscopic level long before symptoms become noticeable. This is why so many people are shocked when numbness or electric pain develops. They assume it started recently when in reality the groundwork was laid much earlier. The progression of nerve damage is gradual and cumulative. Each exposure to metabolic stress, such as elevated blood sugar, chronic inflammation, oxidative stress, or nutrient deficiency, adds a small amount of injury. Individually, these insults may seem insignificant. Collectively, over months and years, they compound. The tiny blood vessels that nourish peripheral nerves begin to narrow and stiffen. Oxygen delivery declines. The protective myelin sheath that insulates nerve fibers starts to thin. Signal transmission becomes less efficient. At this stage, there are no dramatic symptoms. The body compensates. Neighboring nerve fibers adapt. The brain adjusts to subtle changes in signal strength. As the process continues, the damage reaches a threshold where compensation is no longer sufficient. That is when people first notice intermittent tingling, slight numbness, or mild burning sensations. These early symptoms are not random. They are physiological alarms. Tingling often reflects irritated sensory fibers misfiring. Numbness indicates reduced signal conduction. Burning pain can signal inflammation affecting small nerve fibers. Importantly, these are functional disturbances, meaning the nerves are stressed but not yet completely destroyed. This distinction matters because functional damage can often stabilize or partially reverse if the underlying cause is addressed promptly. One reason neuropathy feels sudden is that nerves have a high reserve capacity. They can lose a significant percentage of function before noticeable impairment occurs. When that reserve is exhausted, symptoms appear quickly, creating the illusion of abrupt onset. However, pathological changes, microvascular injury, glycation of proteins, mitochondrial dysfunction, have typically been developing silently. By the time balance problems or persistent numbness set in, structural damage may already be advanced. Another critical factor is that early neuropathy is often dismissed. Mild tingling is attributed to fatigue. Occasional numbness is blamed on posture or circulation. Burning at night is labeled as aging. This normalization delays intervention. Meanwhile, the underlying drivers continue unchecked. Without correction, intermittent symptoms become constant. What began as mild irritation progresses to measurable nerve fiber loss. Protective sensation diminishes, increasing the risk of falls, unnoticed injuries, and long-term disability. Understanding that neuropathy builds quietly reframes the condition entirely. It shifts the focus from symptom suppression to early detection and prevention. Tingling and numbness are not final diagnoses. They are warning signals indicating that nerves are under metabolic or toxic stress. Acting during this early phase can alter the trajectory. Waiting allows cumulative damage to reach a point where recovery becomes limited. Recognizing the slow, silent nature of nerve deterioration is the first step in protecting long-term mobility and independence. Chronic blood sugar spikes are one of the most underestimated drivers of nerve damage, and the critical point is that diabetes is not required for this process to occur. Nerves are metabolically active tissues that depend on stable glucose levels for proper function. While glucose is essential for energy, repeated elevations beyond normal physiological ranges create biochemical stress that peripheral nerves are particularly vulnerable to. It is not a single high reading that causes harm, but the repeated pattern of post-meal spikes that gradually injures nerve fibers over time. When blood sugar rises sharply after meals, excess glucose begins interacting with proteins and lipids in a process known as glycation. This leads to the formation of advanced glycation end products, which stiffen tissues, impair cellular repair mechanisms, and disrupt normal nerve structure. At the same time, elevated glucose increases oxidative stress inside nerve cells. Mitochondria, the energy-producing structures within cells, generate more reactive oxygen species under high glucose conditions. These reactive molecules damage cellular membranes, DNA, and enzymes essential for nerve conduction. Another major mechanism involves the tiny blood vessels that supply peripheral nerves. These microvessels are highly sensitive to metabolic stress. Repeated glucose spikes damage the endothelial lining of these vessels, reducing nitric oxide availability and impairing circulation. As blood flow declines, nerves receive less oxygen and fewer nutrients. Over time, this chronic low-grade ischemia contributes to demyelination and axonal degeneration. The myelin sheath, which acts as insulation to ensure efficient electrical signaling, begins to deteriorate. Without proper insulation, nerve impulses slow down or misfire, producing symptoms such as tingling, burning, numbness, or electric shock sensations. Importantly, many individuals with so-called normal fasting glucose still experience significant postprandial spikes. Fasting levels reflect a single moment in time, typically after several hours without food. They do not capture what happens 1 or 2 hours after consuming refined carbohydrates or sugary beverages. Research has shown that individuals with prediabetes can develop neuropathic changes similar to those seen in type 2 diabetes. The difference is that prediabetes often goes undiagnosed for years, allowing cumulative nerve injury to progress silently. Insulin resistance further compounds the issue. When cells become less responsive to insulin, the body compensates by producing more of it. Chronically elevated insulin levels are associated with systemic inflammation, which itself contributes to nerve damage. Inflammatory cytokines increase vascular permeability, promote oxidative stress, and interfere with nerve repair processes. This creates a self-perpetuating cycle in which metabolic dysfunction fuels inflammation and inflammation accelerates neural injury. Small fiber nerves are usually affected first. These fibers are responsible for pain and temperature sensation, which explains why burning or heightened sensitivity often precedes numbness. As damage advances, larger fibers responsible for vibration sense and balance become involved. This progression underscores why early intervention is critical. The earlier glucose variability is stabilized, the greater the likelihood of halting or slowing structural damage. The essential takeaway is that neuropathy is not exclusively a complication of diagnosed diabetes. It is a consequence of repeated metabolic stress on vulnerable nerve tissue. Eliminating frequent glucose spikes reduces glycation, lowers oxidative stress, improves microvascular function, and decreases inflammatory signaling. Stabilizing blood sugar patterns therefore addresses the root physiological drivers of nerve injury rather than merely masking the resulting pain. The third key point centers on the 3 most common daily sources that silently drive metabolic stress and contribute to nerve damage: liquid sugar, refined carbohydrates eaten alone, and constant snacking. These exposures appear harmless because they are socially normalized and often marketed as convenient or even healthy. However, their physiological impact on blood glucose dynamics makes them particularly harmful to vulnerable nerve tissue over time. Liquid sugar is metabolically aggressive because it bypasses many of the body's natural protective mechanisms. When sugar is consumed in solid form with fiber, digestion slows and glucose enters the bloodstream more gradually. In contrast, beverages such as fruit juice, sweetened tea, soda, flavored coffee drinks, and even many smoothies deliver a concentrated glucose load with minimal fiber buffering. The stomach empties quickly, intestinal absorption is rapid, and blood sugar rises sharply within minutes. These spikes trigger large insulin responses and create oxidative stress. Repeated daily exposure leads to glycation of proteins, microvascular injury, and inflammatory signaling that directly affects peripheral nerves. Because liquids do not create the same satiety signals as whole foods, they also encourage excess caloric intake, compounding metabolic strain. Refined carbohydrates consumed in isolation represent the second major source of hidden nerve stress. Foods such as white bread, crackers, cereal, white rice, and pasta are rapidly digested due to their low fiber and high glycemic index. When eaten alone, without accompanying protein or fat, gastric emptying is accelerated and glucose absorption occurs quickly. The absence of macronutrient balance removes the moderating effect that slows carbohydrate breakdown. This results in pronounced postprandial glucose excursions. Over time, these repetitive surges contribute to insulin resistance, endothelial dysfunction, and reduced microcirculation to nerve fibers. The damage is not immediate, but cumulative. Each spike adds incremental stress to the delicate structures responsible for sensation and balance. The third source, constant snacking, disrupts metabolic recovery. After a meal, insulin rises to facilitate glucose uptake into cells. Under normal circumstances, insulin levels gradually decline, allowing the body to enter a lower insulin state in which repair processes, fat metabolism, and cellular cleanup mechanisms become active. When food, particularly carbohydrate-containing snacks, is consumed every few hours, insulin remains chronically elevated. This sustained elevation prevents metabolic rest and promotes ongoing low-grade inflammation. Peripheral nerves, already sensitive to fluctuations in glucose and inflammatory mediators, are exposed to continuous biochemical stress without sufficient recovery intervals. Chronic hyperinsulinemia also interferes with mitochondrial efficiency and increases the production of reactive oxygen species. In the context of nerve health, this means impaired energy production within axons and increased structural vulnerability. Small sensory fibers, which lack robust regenerative capacity, are often affected first. Patients may initially notice subtle burning or hypersensitivity that progresses gradually if dietary patterns remain unchanged. These three exposures share a common mechanism. They destabilize glucose regulation and amplify inflammatory pathways. While each individual episode may seem trivial, the repetitive pattern over months and years drives structural and functional nerve deterioration. Recognizing these hidden contributors allows for targeted behavioral modification that reduces metabolic volatility and lowers cumulative neural stress, creating conditions more favorable for stabilization and preservation of peripheral nerve function. Vitamin B12 plays a fundamental role in maintaining the structural and functional integrity of the nervous system, and its deficiency is one of the most overlooked yet clinically significant contributors to neuropathy. Unlike blood sugar toxicity, which damages nerves through metabolic stress, B12 deficiency impairs the very architecture that allows nerves to transmit signals efficiently. Peripheral nerves rely on a fatty insulating layer called myelin, which surrounds axons and enables rapid electrical conduction. Vitamin B12 is essential for myelin synthesis and maintenance. When levels decline, this protective sheath begins to deteriorate, leading to slowed conduction velocity, signal distortion, and eventually structural nerve injury. The mechanism involves impaired methylation and disrupted DNA synthesis within nerve cells. Vitamin B12 acts as a cofactor in critical biochemical reactions, particularly in the conversion of homocysteine to methionine. When B12 is insufficient, homocysteine levels rise and methylation processes become inefficient. This biochemical disruption affects myelin stability and repair capacity. Over time, demyelination exposes nerve fibers, making them vulnerable to oxidative stress and inflammatory damage. Patients may initially experience subtle numbness, tingling, or a pins and needles sensation, often beginning in the feet and progressing upward in a stocking distribution pattern. One of the most concerning aspects of B12-related neuropathy is that it can progress silently, similar to metabolic neuropathy. Early laboratory abnormalities may go unnoticed because standard serum B12 tests can appear within low normal ranges despite functional deficiency. Measuring methylmalonic acid can provide more accurate insight, as elevated levels indicate impaired B12-dependent metabolic pathways. Without proper evaluation, symptoms are frequently misattributed to aging, circulation issues, or idiopathic neuropathy. Medication use is a major contributing factor. Long-term use of certain drugs, particularly metformin and proton pump inhibitors, can impair B12 absorption. Metformin alters intestinal motility and interferes with calcium-dependent uptake of the vitamin in the terminal ileum. Proton pump inhibitors reduce gastric acid production, which is necessary to release B12 from dietary protein. Over years of therapy, this gradual malabsorption can produce clinically significant deficiency. Because these medications are commonly prescribed in older adults, the cumulative risk becomes substantial. Dietary patterns also play a role. Vitamin B12 is found primarily in animal-based foods such as meat, fish, eggs, and dairy. Individuals following strict vegetarian or vegan diets without supplementation are at higher risk. Additionally, age-related decline in intrinsic factor production and gastric acid secretion further compromises absorption in seniors, even with adequate dietary intake. Importantly, early identification and correction of B12 deficiency can halt progression of neuropathy and, in some cases, partially reverse functional impairment. However, advanced demyelination and axonal loss may not fully recover. This underscores the necessity of prompt detection. Neuropathy due to B12 deficiency is not merely a nutritional inconvenience. It represents a structural vulnerability within the nervous system that, if unaddressed, can lead to balance disturbances, gait instability, and increased fall risk. Because B12 deficiency is both detectable and treatable, overlooking it represents a missed therapeutic opportunity. Evaluating B12 status, especially in individuals with neuropathic symptoms and long-term medication use, is a critical component of comprehensive nerve health assessment and prevention strategy. The 5-rule framework is designed to interrupt the core drivers of neuropathy progression by stabilizing blood sugar, lowering inflammation, improving circulation, and reducing cumulative nerve stress. It is not a short-term symptom management strategy, but a metabolic reset protocol that targets the underlying mechanisms responsible for nerve deterioration. Each rule addresses a specific physiological vulnerability, and together they create an environment that supports neural stabilization. Eliminating liquid sugar is foundational because liquid carbohydrates produce the most rapid and exaggerated glucose spikes. Without fiber or structural complexity to slow digestion, glucose enters the bloodstream quickly, triggering high insulin release and oxidative stress. Repeated spikes accelerate glycation and microvascular injury, both of which impair nerve perfusion and function. By restricting beverages to water, unsweetened tea, or black coffee, one removes a major driver of metabolic volatility. This single change often reduces daily glucose variability more than any supplement could. Ensuring protein intake with every meal and snack slows gastric emptying and moderates carbohydrate absorption. Protein stimulates glucagon and incretin hormones that balance insulin response, reducing postprandial glucose excursions. When carbohydrates are consumed in isolation, blood sugar rises sharply. When combined with protein and healthy fats, the glycemic curve flattens. Lower peaks mean less oxidative stress, less endothelial dysfunction, and reduced inflammatory signaling directed at peripheral nerves. This macronutrient pairing strategy transforms the same foods into metabolically safer options. Walking for 10 minutes after meals leverages skeletal muscle as a glucose disposal system. Contracting muscle fibers increase glucose uptake independent of insulin through activation of GLUT4 transporters. Even brief postprandial movement significantly reduces peak glucose levels and shortens the duration of hyperglycemia. For peripheral nerves, this translates into less exposure to glycotoxic stress. Additionally, regular light activity improves endothelial function and enhances microcirculation, supporting oxygen and nutrient delivery to nerve tissue. Stopping food intake 3 hours before bedtime reduces nocturnal insulin elevation and allows metabolic recovery. Late-night eating prolongs hyperglycemia and disrupts circadian regulation of glucose metabolism. During fasting intervals, insulin levels decline, and cellular repair processes such as autophagy become more active. While nerve regeneration is slow, reducing continuous metabolic strain creates conditions more favorable for stabilization. Time-restricted eating also improves insulin sensitivity over time, further dampening glucose variability. Daily foot checks serve a protective rather than metabolic function. As neuropathy progresses, sensory loss may prevent awareness of cuts, pressure injuries, or temperature extremes. Minor wounds can develop into infections if unnoticed. Early identification prevents complications that could lead to ulceration or impaired mobility. This practice acknowledges that neuropathy is not solely about discomfort. It is about preserving structural integrity and preventing secondary damage. When implemented consistently for 30 days, these rules allow individuals to objectively assess symptom trends. Improvement suggests that metabolic stress was a primary driver. Stability indicates the need for further evaluation, including nutritional deficiencies or autoimmune factors. Worsening symptoms require more advanced neurological assessment. The framework emphasizes disciplined consistency rather than rapid results, recognizing that nerves heal slowly and require sustained reduction in metabolic and inflammatory burden to alter the trajectory of progression.